Good morning. I'm substituting for Dr. Rajan, and after me, Dr. Manoj is also substituting for him. I bring a combined effort of some of our colleagues, Anupam, Savneet, Sukriti, Sanal, and many, many more whom I have not been able to list out. Liver is a regenerating organ singularly gifted to restore 100% of weight and body ratio post hepatectomy. This phenomena is called hepatostat. And Prometheus, who was punished by the god that during the day the vultures would nibble at the liver, then in the night after rest, the liver would regrow. I'll try and cover with you a little bit of the basic science, maybe 1% of all, in partial hepatectomy, LDLD, fatty liver, cytokines, and the sequences. This is an old diagram, but very simple to say that blood flows from the portal vein to the central vein and to the heart. Bile and the lymph flow in the reverse direction. And the life of a hepatocyte is generally 120 days, but it can multiply many, many times more. A larger view shows, and the recent upthinking is that it is not the bile duct area and the canal of Herring where all the regeneration takes place. In fact, a wave can start from here in the patients, but it is the bipotential biliary epithelial cells which can go this direction or this direction. Normally, it is the last cell plate around the central vein which regenerates last. So it is this area which is well oxygenated with blood supplies and therefore can start the process of regeneration. This diagram drawn by Anupam is simple and clear. Which are the players? The liver cells, the parenchyma, hepatocytes, cholangiocytes, biliary cells, non-parenchymal cells, Kupffer, L-sex, stellate cells, and the immune cells. The second tier is hepatic stem cells, progenitor cells, and third tier is the bone marrow. They all play at different times and depending on the injury to the liver. Here you would see that normally it is the resident hepatocytes will multiply by themselves, self-replication. There is no play of HSCs or macrophages. But in the case of acute injury, you will see the involvement of the resident macrophages, and I'll show that later one more time to you, while they also have the hepatocytes which will be multiplying. Not only is the hypertrophy, multiplication, but also hypertrophy of the hepatocytes can take place. While in the chronic injury, ongoing injury, there is stimulation of stellate cells, which are one of the major players, and the ECM, the extracellular matrix, which comes in the play. This simple diagram gives you what happens in the very first minute of 70% hepatectomy. It is 0 to 30 minutes. In 1 minute's time, you will have the urokinase type plasminogen activator UPA from LSEC. Now this will come out and converts plasminogen to plasmin. And in the matrix, you have pro-HGF, hepatocyte growth factor, which is converted to HGF. And there is plenty of HGF around which comes into the play. So pro-HGF to HGF is among the first step in the very first minute of hepatectomy or so. And then, of course, release of VEGF, the nitric oxide, and then the modeling keeps on starting. There is also very important that once hepatectomy occurs, the loss of volume, the neuronal message goes to the brain in the hypothalamus, and in 15 minutes, the bile acids will start coming down. So there is local, there is neuronal, and lastly, hemodynamic. When the blood flow comes, the same amount of liver which was there is now reduced to 30%. 70% liver has gone. So this volume of blood is too much, 3 times more for the remnant liver. And this leads to de-arterialization. Portal vein comes in, but artery goes down. And this releases a series of substances, and these include IL-6 and TNF. Let's go further. So this science paper beautifully showed that the release first is of TGF beta, and the break of TGF beta is broken down, means now the cells can proliferate. So loss of integrin, ILK signaling, and the release of angiopoietin 2 from L6. So TGF beta is now not, it is inhibited, and there is substantial space available for hepatocytes to grow. Also, the Kupffer cells come into play within 4 to 6 hours, and they will now start giving messages to the hepatocytes. They will give TNF alpha, IL-6, and because of which there is a start of the process of proliferation, and priming for proliferation starts. See, in few minutes time, within 5 to 144 hours, this has not come out well, the bile acids, the noradrenaline, 5-hydroxytryptamine, they all come. And you also have epidermal growth factor. I'll show it to you from where it comes. The stromal derived factor 1, all these are locally available, and they will work on the hepatocyte through the EGFR receptor and the phase of cyclin D1, and the regeneration starts. Simultaneously, the HGF, which is in the extracellular matrix, will also work upon the cholangiocytes. The endothelial cells will start working mainly through CXCR7 and ID1, which is inhibitor of binding DNA1 protein, which is the one because of which you have proliferation. So ID1 also will be released. Subsequently, you have a orchestra of players, VEGF, angiopoietin 1 and 2, first number 2, and then angiopoietin 1, and then TGF alpha, not beta. And then you will see that oxidative phosphorylation and glycolysis, they all have a metabolic reprogram. How do you stop after partial hepatectomy? In 5 days or so, there is a inhibition. Yes, enough is enough. It is 100% of the liver is back, and then it will slowly start stopping the process. So starting in 1 minute, within first 4 hours, within 5 to 144 hours, and then by day 5, the termination of liver regeneration occurs. This is in a normal, healthy animal, mouse, or a rat model. And this is the way the waves come. So within 6 to 12 hours, the hepatocytes, followed by cholangiocytes, followed by Kupffer cells and Ito cells, and then sinusoidal endothelial cells will start playing. And the orchestra plays beautifully with the cell cycle. I want to stress upon this that you have major players which are local, endocrinal, neuronal, and we forget duodenum. Duodenum has Brunner's gland. Brunner's gland is one of the pacemakers. Brunner's gland releases three things: TGF alpha, not beta, EGF, epidermal derived growth factors. They all come from Brunner's gland and they come through the portal blood into the liver. So in a cirrhotic, you look carefully, you will hardly find Brunner's gland or so. The central mechanisms are hepatocyte growth factor and epidermal derived growth factor and the receptors. They are the inductors of proliferation of both parenchymal and non-parenchymal cells. And of course, the auxiliary mechanisms include non-parenchymal immune cells in bile acids and other organs. This work done by our colleague Sridhar in his MCH thesis, very interesting, and I want to highlight this part. In hepatectomy, right lobe without MHV, this much volume is taken out. Correct me, Sridhar. And the regenerated volume was this much. For me, what was interesting is on postoperative day 37, you have HGF coming. IL-6 came first and TNF-alpha came first. Maybe in the liver itself, HGF will come within few minutes to an hour, but in blood, it does not because it is used there. In a patient who has fatty liver, like a donor, hepatocytes cannot enter the cell cycle very efficiently because of mitochondrial dysfunction and oxidative stress. And of course, defects in the Kupffer cell mediated hepatocyte priming, and therefore we have a post-hepatectomy liver failure if you have more than 30% of fat in the liver. This work also done by the surgery department, Dr. Pamecha, and the team by Anish. This is a very interesting work. This came in Annals of Surgery. What it showed was if you have a low calorie for the donor, the liver regeneration occurs fast. To summarize, those who had low calorie intake had a better liver volume, the percentage of liver restored in the intervention arm than in the control arm. So there was an increase in regenerative cytokines, growth factors. So keep your donors lean and fit. Let's go something on the liver failure. Single line message: liver failure is failure of regeneration. If you cut the liver, it has to come back. If you damage the liver, it has to regenerate. So if the liver injury is more and regeneration of all these three tiers is less, there will be liver failure. So let's see what happens when the cells are dying or dead. So here is an area of necrosis. This necrosis has to be removed, and this is removed by macrophages, and efferocytosis is a process by which you can remove the dead cells. If there is a poor clearance of necrosis, it means the road is filled up with corpses, there will be no regeneration. So one of the rate limiting steps, and the first is this. So when you need more, you get it from bone marrow also. The second phase, as I told you, the hepatocyte priming, where you have TLRs and you have the TNF alpha coming in and IL-6 coming, and the STAT3 and the pathway starts. The next process is cell proliferation, and the last one is ductular reaction. And this I've already explained you. Ductular reaction is a method by which cholangiocytes participate, and they have bidirectional. If there is more injury of the bile duct, hepatocytes will come. If there is more injury of the liver, the cholangiocytes will come and make hepatocytes also. So a defective clearance or a defective TNF alpha or cyclin D1 signaling will probably cause more of liver injury. Now, this beautiful figure tells you how the monocytes from the blood are important players. So, monocyte derived macrophages. So, I told you there is a necrosis, there is an injury due to alcohol or paracetamol or drugs. This necrotic lesion has to be cleared, and for this, the monocyte-derived macrophages are picked up and they will try and kill it. And over a period of 48 to 72 hours, they will kill and clear the debris, and they will have the contraction of the necrosed area so that new cells, new hepatocytes can pick up. So clearance of the dead is important. And based on this, the group from Stuart Forbes designed what is known as alternatively activated macrophages. And what they did was they took up the bone marrow derived macrophages, converted them into active macrophages from inactive, and they showed that because of this, you will be able to clear a lot of cell debris, the phagocytosis, and you clear and have good efferocytosis to allow hepatocyte and endothelial proliferation. Why regeneration fails in CLD? And this is the question with which Anupam and myself got engaged several years ago. And let's walk through what happens in this. It is now the involvement. So our first lucky break came when Chhagan did this work, which came on the cover of Hepatology 2016 October issue. In a normal liver, you have cells where you have hematopoietic stem cells, HSCs, you have Schwann cells, you have sympathetic neurons, and you have what is nestin positive MSCs. So nestin positive MSCs are the ones which create further generation of cells. When there is a cirrhotic liver, initially the marrow does more and more work. It is a stressed marrow. But finally, when they come to us in child's B or C with a MELD of 15 and above, you will find these signals have already dried out and it is an exhausted marrow. So if you use this marrow and give it to the patient, this is not going to work. So we further went down what comes first. Is it the bone marrow which causes the liver injury, or is it the liver injury which leads to marrow failure? So the bone marrow failure precedes by 3 weeks the regeneration failure. So here, healthy fibrosis, bridging fibrosis week 6, and compensated cirrhosis by week 10. Now, while the fibrosis is progressing, regeneration also progresses. But over a period of time, by week 6 or so, the long-term hematopoietic stem cells, they start declining. MSCs start declining even by week 3 to 4. So in an animal model, it was shown that bone marrow regeneration precedes liver regeneration and failure precedes. And this was seen when an ACLF model was produced by an additional insult, when ascites, jaundice, and ammonia were also increased, liver regeneration was totally absent. This was also seen in the thesis by Smriti. And this work in the gut, it showed clearly that there is a reduced Ki67 hepatocytes, They are decreased in patients who have got acute liver failure because the regeneration potential has gone down. And this is in alcohol patients. In alcohol patient, this is alcoholic hepatitis. There is a significant reduction in the regeneration. So the cholangiocyte commitment, the failure of cholangiocytes to commit to hepatocytes does not occur in alcoholic hepatitis. What Smriti showed is that in patients with ACLF, there is a lot of engagement of progenitor cells. Compared to ALF, you see all the brown dots, they are Ki61 positive, but in ACLF, they are not involved. So hepatocytes are not contributing to regeneration in ACLF while they do it in ALF. The clearance of necrosis, the DAMS and PAMS, and this is the ongoing work of Sunidhi. And Sunidhi has shown, compared to healthy, in cirrhosis, there is a reduction in efferocytosis from 93% to 56%. In decompensated, it is 15%, and in ACLF, it is 9%. So dead cells are not cleared by macrophages, and this leads to several, loss of pathogenic potential of macrophages. To summarize again, the work done by Smriti is here. Compare acute liver failure with acute and chronic liver failure. In acute liver failure, the hepatocyte proliferation goes on. The stromal-derived factor, the CXCR4 and 7, they will release the ID1, the inhibitor of DNA binding 1 protein, which, if it is inhibited, there is a cell proliferation. This will go on. But in acute and chronic liver failure, this cycle is broken. There is no ID1, there is no SDF or very little, and this is shown in these plots. And also, it is a process in which cell regeneration does not occur. Therefore, you need the second tier, that is the progenitor cells. The first tier is hepatocytes and its own cells. Second tier is when you need cholangiocytes or progenitor cells. So in this, also Anupam showed very beautifully that the oxygen consumption rate in patients with cirrhosis and ACLF compared to controls is markedly low. So these monocytes or macrophages have poor oxygen consumption capacity. Their basal respiration or extracellular respiration, their ability to handle the endotoxins and phagocytosis is markedly decreased. This we summarized in a recent review in ACLF. So there is a necrosis clearance is poor. Hepatocyte priming is poor. The parenchymal and non-parenchymal cell proliferation is poor, and ductular reaction is increased. This is the orchestra, although we know only 1%, but this is the schemata of things which is happening. Let's see, having this, can we apply? So my first statement, and I want this to be done by next generation, liver generation is ongoing in cirrhosis and ACLF. However, it is impaired, it is defective, can be supplemented. And here, just to show you, ALF, you have regeneration, cirrhosis poor, ACLF very poor. So self-replication is inadequate. Progenitor cells, yes, and much more in ACLF. So based on these data and earlier work, we started using growth factors. What does GCSF do? It works on bone marrow. It starts the trafficking and stimulation of the marrow to release cells, the mature adult progenitor cells and others. It decreases apoptosis. The CD34 come into the blood, and neutrophils, macrophages, monocytes, they come and they start some regeneration in the liver and reduce fibrosis. As also shown in this study, that in ACLF, when given GCSF, you have almost 2 times more the cells, the CD34 and 133 coming in. And this was shown by Vishal in his work that those who received GCSF had a better survival than those who did not. And Risha Moru gave this beautiful concept diagram. GCSF will work on the liver to stimulate progenitors and work on the marrow to mobilize CD34 stem cells to help in regeneration of the liver. The meta-analysis shows that GCSF compared to controls lowers the MELD, reduces sepsis, and higher 90-day survival. However, all cirrhosis are not going to respond. The work has to be very clear on patient selection. Combination of GCSF with erythropoietin or we change to darbepoetin was one which was done by Chandan, and now Shreya is undertaking this trial. I hope she has some reasonable results. In Chandan's work, we showed that GCSF plus darbepoetin compared to placebo given for 2 weeks period had a better overall survival, and we had more mobilization of bone marrow stem cells which came to the this is pre and this is post CD34 and CD133. The density increased. Then came a concept of GCSF plus TLR4 inhibitors to TAC242. This is an animal study. So if you give GCSF, which may already be high there, but it is still inadequate, you give TLR4 inhibitors and it might be helpful or so. Is there a role of cell therapy? Well, mesenchymal stem cells or MSC, there is no stem cell in the liver nowadays, nobody believes, because stem cells take a lot of time. So instead of that, the local process starts immediately. So MSCs are immunomodulatory, they are trophic, then antimicrobial, they have self-renewal, and they are multipotent. So there are several sources. Marrow, we used to work on that. Adipose tissue, Sanal had worked on it. Perinatal, where probably the immunogenicity is very, very low. So you can use Wharton jelly, umbilical cord, or placenta. We are using umbilical cord. And then you can also have MSC-like stem cells from iPSCs. So this is again the work from Dr. Anupam's lab, a simplified diagram. Cirrhosis, acute injury causes ACLF, which releases DAMPs and PAMPs. The monocytes are overwhelmed, so there is increased systemic inflammation, endotoxemia. There is a bioenergy failure because of the increased oxygen consumption, decreased glycolysis, and oxidative phosphorylation. And there is a functional exhaustion of monocytes. And because of this, there can be an immune paralysis leading to sepsis, organ failure, and there is no resolution of the injury. Now, in case we are able to provide these MSCs some good mitochondria, and we are able to give these mitochondria and the monocytes new life, maybe we can regenerate and improve the function in these patients. Several studies have been done using MSCs. They all have been given IV. Several of them have shown improved liver function, and some of them have shown, probably one of them have shown no benefit of this. So the field is very, very open. The challenge is when you give IV, we do not know where the MSCs will be homing, whether they will go to lung, which is the first pass trap for them, or they will go to any other organ. So this remains a challenge. So what we did was we use patients, and this is umbilical cord MSC therapy in steroid non-responsive alcoholic hepatitis. In these patients, we had given IV, and there was a definite benefit in the delta MELD. These are 7 patients. I think now there may be 9 or 10. No major adverse effects. So after 1 month or so, there is a reduction in MELD. Then we thought, why don't we give it intra-arterial? And we took the help of IR, Dr. Amar. These are again 7 patients. And he designed a new protocol. And he said, we will give 60% in the right lobe, 20% in the left lobe, 10% in SMA, and 10% in IMA to give every area, the intestine as well as the liver, both lobes, some benefit. And we have 7 patients, and decrease in delta MELD has been marginal, but no side effects. And now we are using 5 to 10, 10 raised to power 6 cells per kilogram. It needs to be 10 raised to power 8, but we are trying, and we have now a GMP facility available. This is the work by Fusheng Wang. Fusheng Wang worked to find out the study, what should be the ideal dose. I'll just summarize 2 into 10 raised to power 8 MSCs are the most ideal dose. And also he found a new substance called MX1 positive monocytes. And this MX1 positive monocytes probably are the one we have to watch. They are the ones which will stimulate. The next for us is the future extracellular vesicles. So those cells, MSCs, will also give cargoes in the extracellular vesicles. So when MSCs are expensive, EVs can be cell-free, they can be stored for months, and they can deliver the RNA positive proteins without risk. So the new area is MSCs plus extracellular vesicles combined. And there are several studies undergoing, and we are hopefully going to start. It is still in these initial stages, but some success. So you have mesenchymal stem cells plus extracellular vesicles derived. Can macrophages themselves, which are defective, can they give you some benefit? And this is the work by Stuart Forbes in Nature Medicine. He showed that when you give autologous macrophages, and he found there is no added advantage whether you give in patients with ALD or MSC, but it is safe. Then we thought of another novel, rather funny idea. Can we not do a bone marrow transplant in a patient with liver disease? So you can't get a new liver, give him a bone marrow. There were several problems, but we tried this in the animal model. And just to give you an idea, restoring bone marrow hematopoietic stem cells is like a bone marrow transplant in a patient with cirrhosis, and a proof of concept was published. Once we gave this healthy bone marrow, the allogenic bone marrow, the animals did much better. The hepatocyte death, the neutrophil inflammation, all those were markedly decreased with a better survival. So let me summarize and give you a carry home message. Liver regeneration is the fundamental science. This institute is committed, but we are very limited because of our limited knowledge. We have the best transplant team, but still maybe 1 in 100 gets transplant. So we have an unmet need. All 3 tiers are needed for liver regeneration after acute liver injury, ALF, ACLF. Hepatocyte priming, clearance of necrotic cells is the first important step. Macrophages are key, but they are reduced and dysfunctional in CLD and cirrhosis. Bone marrow hematopoiesis restores liver macrophages, so you need a good bone marrow. Exercise and fill up the marrow. And there are several regenerative therapies. We are still in nursery. We are using GCSF, darbepoetin, and maybe many more are in the pipeline. Then MSCs improve. We are trying this, and we are planning to add EVs. What I need, and importantly, this lesson and message is to all. We need next generation of hepatologists who can take this forward with brighter ideas and more commitment and many more cell biologists, so that we have a group which can take this area into next level. Thank you.
Morning, sir. As usual, brilliant and excellent. The vision and the work you're doing. And ILBC is also doing such a phenomenal work. Any comments or?
So I have a small question, which definitely is not pertaining to the cell biology, but so you mentioned about the fatty liver disease and the regeneration in that. So while you have patients who have donors who have fatty liver, and we ask for a weight loss and program, and then of course they are donating. So what do you think is the best biomarker till date which can tell you that there will be adequate liver regeneration after hepatectomy?
It's a good question. What is the best marker for liver regeneration? I would say if the fat comes down and the ALT is half of normal, it should be taken as a good liver for regeneration. That should be the best.
Sir, very nice, sir. Really inciting. So just few queries and comment. So MSC injection in hepatic artery, is it based on some previous evidence, or this was a thought which came and you started doing it? Because I would have thought arterial flow is very high and the cells will just wash away. Most of the time, people, when they want to inject something into the liver which remains in the liver, will be into the portal vein, because that's where the pressures are very low, and these cells will then go to the sinusoidal endothelium, and then they may adhere there, and then they may do the proliferation thing. So I'm just curious, why artery rather than portal vein?
Very good question, and we have no mechanism of cell tracking. So if we can label them by ferromagnetic material, we can trace where the cell is located. And the cardiac will finally go into the sinusoid where it will cause. My worry was that it can cause clotting, it can cause coagulation, but there are two reports from here where they have located. And now I'm fine that the hepatocyte, the MSC will stay there and they will start the paracrine work. We have to see what happens. We have not done, but we will take it forward. This is a good question. But it is better than IV. IV goes to lung.
IV not, sir. I'm just saying direct portal vein implantation. The risk is portal vein thrombosis risk is there, which happens with the
Puncture, we used to do portal
intrahepatic, direct intrahepatic portal vein implantation, puncture and implantation. Directly implantation, sir. So another one, you showed one of the diagrams about endothelial injuries in ALF and ACLFs. That's an interesting, I think, diagram, which was, I think, published by Anupam as well in Hepatology International. There was a line diagram showing there is an endothelial damage in patients with ALF and ACLF, right? And that would have thought to be a trigger point for liver regeneration. Now, in conceptually, if you see in ALF and ACLF, it is more about necrosis, more necrosis, lesser regeneration. And when the balance goes out of A, that's where you get into failure and everything. So I'm not sure whether endothelial damage per se will apply to patients with ALF and ACLF, because endothelial damage applies in patients with partial hepatectomy, where you get increased portal flow, and then there is an sinusoidal stretch and damage. If the stretch is more, then it will lead to damage, and that actually incites liver regeneration. But can we apply same concept to ALF and ACLF?
It's a very good question. I think we remain open to whether endothelial cells contribute enough for HCLF regeneration. They probably do not. And it is because of this. First, the endothelial cells come in the first year. Before progenitor, the second year comes. The Anupam Smriti got short clearly that in ACLF endothelial cells do not play a major role, and in lower levels of macrophages, so protective cells come and start working. But I think I've overstepped my time, and I'll be happy, and I'm happy that some of the people have got this initiative, and I want to thank Shreya for taking up this new thesis. I hope we have a unit where regeneration can also become point to Thank you all. Right. So this is an ignored topic and often very neglected aspect to different topics. These are the issues that we need to discuss. How to define sexual dysfunction, how to evaluate patients, what is the prevalence, what are the associated factors, and what are the mechanisms, what is the effect on quality of life. Because ultimately we are focusing on to improve the quality of life of our patients. And how do we manage this, and how does it behave after liver transplant? So male sexual dysfunction includes a range of conditions which include from low libido, erectile dysfunction, infertility and orgasm disorders, PMS disease. And again, there are sub-classifications based on the various mechanisms. Now, this is female sexual dysfunction. Again, there is a range of conditions. We need to dissect which aspect of sexual dysfunction is affected in the particular patient. Low libido, arousal disorders, there could be orgasmic issues, there could be painful intercourse, dyspnea with any sorts. These are the problems. So, how do we evaluate the patients? So, first, history and physical examination. We have to listen to the patient. We have to devote some time to the patient. The sexual history should be very detailed. There are questionnaires that you will see, and involved partner with that. Medical history is very important. Age is one of the factors. Diabetes, hypertension, obesity, medications. Many medications used in cirrhosis can contribute to sexual dysfunctions, smoking, alcohol. These are all contributing factors. And psychological assessment is very important. Anxiety, depression, stressors, relationship problems are all contributed to each other. And we must involve other departments like psychology or psychiatry department also. Physical examination, if there are any local deformities, prostatic disorders, hypogonadism, CNS, CVS, neurological examinations, these are very important. For male, the first is the International Index of Erectile Functional Questionnaire. This discusses over the first 4 weeks. These are the areas that need to be assessed: erectile function, orgasmic function, sexual desire, intercourse satisfaction, and overall satisfaction. And based on the overall score, if the score is less than 25, then it is erectile dysfunction, and then according to severity, we can grade. For example, between 6 to 10, it is severe, 11 to 16, moderate, and 17 to 25, mild. 26 to 30 is normal. So this is one questionnaire, IIEF. This is the shortened version of the same IIEF-5, only 5 questions. And in this, if less than 21, it is called erectile dysfunction. And then subsequently, it can be quantified according to the severity. For female sexual function index, again, over past 4 weeks, there are questions assessing sexual function domains. And
In this total score, less than 55 is female sexual dysfunction, and for each domain, there are specific cutoffs so that there could be specific domain disorders also. And this Arizona Sexual Experiences Scale, this can be used for both male and female. This assesses questionnaire over the past week. Previous questionnaires were past 4 weeks, now this is for past week. And there are 5 questions and score ranging from 5 to 300. And here higher scores indicate more sexual dysfunction. And again, it can be defined as total 19 or more, it is female sexual dysfunction, or 5 or more on any item, or 4 or more on 3 items. So what is the prevalence? So if you look at the erectile dysfunction, that is male sexual dysfunction, prevalence is quite high. There have been various studies, but there is also positive studies. First study on NAFLD prevalence is quite high, 45 to 67%, and degree of fat correlated with erectile dysfunction. And as we have seen, risk factors were diabetes, hypertension, obesity, and psychogenic. Another study on chronic viral hepatitis, again 40 to 78%, more with diabetes, 92% if they have diabetes, more with cirrhosis, 85%. SCV had more as compared to HBP, and the reason was endothelial inflammation or cryoglobulinemia, that is more common in SCV. And a meta-analysis in patients with cirrhosis, we found that up to 80% of patients have erectile dysfunction. If it is decompensated, it could reach about 90%. Similarly, studies for female sexual dysfunction, prevalence. One study in chronic liver disease patients with mixed etiology found that reduced sexual desire in 33%, reduced arousal in 18%, difficulty in orgasm 25%, and coital dysfunction in 25%. Similarly, there have been other studies, non-cirrhotic MASLD, hepatitis B, hepatitis C, and patients waiting liver transplant. Again, very high incidence of even female sexual dysfunction, but these studies may not be adequately reported. And these issues, because socio-cultural issues are very important, patients may be shy to come up with these problems. So you need to make comfortable the patients so that they come out with these problems. This was one study which was done here in the pathology department. This was on male 21 to 60, cirrhosis of any etiology and high performance status. So, of 400 patients, 72.3% had erectile dysfunction. It's quite high. And almost half of them had severe ED, or there was no attempt at all. So 70% had erectile dysfunction, and of those 50% had very severe erectile dysfunction. Now, what are the associated factors and mechanisms of sexual dysfunction? So these are the associated factors: overall health status, age, diabetes, hypertension, mental status, depression, and anxiety. And in this study, majority of the patients with ED had generalized anxiety disorder and major depression. This was done at ILBS, the pathology department. So GAD-7 score, which indicates anxiety, almost half of the patients, and PHQ-9 score, which indicates severe depression. Again, about half of the patients, 50% of the patients have anxiety and depression. Now, severity of chronic liver disease. So, in the same study, if CTP-C is there, 90% prevalence is there. CTP-A, about 65%, CTP-B, 72%, and CTP-C, 90%. So, it increases with CTP scores. And multivariable analysis of factors associated with ED showed that age, duration of cirrhosis, CTP status, even baseline HVPG, baseline prolactin, anxiety, depression, and DEXA ASMI. That means muscle skeletal mass is also important part. Now, what are the mechanisms? We have gonadal dysfunction, decreased testosterone, decreased free testosterone, increased estradiol, increased prolactin, drugs, toxin, medications, insulin resistance. We'll discuss one by one. So in this study done at ILBS, multi-factor, multivariable analysis. What we saw this completely saw. So in this study, it was found that total testosterone was low, free testosterone was low, LH was higher, and prolactin was higher among patients with erectile dysfunction. So hormonal imbalance also plays a role. Now, drugs and toxins. Alcohol, non-selective beta blockers commonly used in cirrhosis, spironolactone, immunosuppressants like azathioprine, tacrolimus. These are the drugs that are commonly associated with erectile dysfunction. Insulin resistance, ER stress, vascular endothelial dysfunction, arteriosclerosis, oxidative stress, inflammation, apoptosis, anemia can itself lead to erectile dysfunction. These are some of the correctable factors. Now, effect on quality of life. In the same study from ILBS, we found that patients with erectile dysfunction have poor quality of life across all the domains. This was done using SF36 version 2. And across all the domains, physical functioning, role physical score, bodily pain score, vitality score, overall score, physical and mental, all the domains were affected and led to very poor quality of life of the patients. As far as the management is concerned, this algorithm is for sexual dysfunction in chronic liver disease. Risk factor management is very important. Alcohol, smoking, obesity, medication, diabetes control, lipids control, diabetes. And if there is erectile dysfunction, then assessment, psychological assessment is very important. Then phosphodiesterase 5 inhibitors, sildenafil, tadalafil can be used. If erectile dysfunction with low libido and we find that testosterone is low, then besides psychosocial interventions, testosterone can be used injectable or topical. But it is a multidisciplinary management and we might need referral to specialized management for patients requiring vascular, neurological, cardiac, pelvic, perineal, penile, and so on and so forth. This is management algorithm for female sexual dysfunction. Again, first risk factors. Then if there is low libido, then after psychosocial interventions, then there is a drug, bremelanotide. This is a melanocortin receptor agonist, FDA approved, but there is no safety profile in cirrhosis, so you cannot say whether we should use it or not. If there is a pelvic floor dysfunction, then we have to assess and manage accordingly with referral to urogynecologist and so on. This was a study done at ILBS by Rakesh Gilbis. Tadalafil for erectile dysfunction in cirrhosis. We included patients with erectile dysfunction. And please note the exclusion criteria. CTP more than equal to 10 were excluded. And obviously, we have to evaluate cardiac for unstable angina and other things before we start. So tadalafil dose was 10 milligram versus placebo. And this improved erectile dysfunction at 12 weeks of therapy across all the domains. And as we can see, erectile function and orgasmic function, sexual desire, everything on every domain, it improved after 12 weeks of therapy. It also improved anxiety and depression scores at 12 weeks of therapy. And obviously, it improved the SF36 quality of life scores, including the mental component of summary score. Obviously, physical component of the summary score did not improve because mental component is more important. Importantly, there were no adverse effects on HVPG at 12 weeks of therapy. Baseline HVPG was similar, and at 12 weeks also, delta HVPG, delta decline more than 20%, and HVPG less than 10, all were similar in both the groups, tadalafil versus placebo. And there were no major side effects of tadalafil. However, as the side effects are of low incidence, so larger studies would be needed to evaluate for rarer side effects. Now, effect on liver transplant. So cross liver transplant cross-sectional studies are there, which show that males have more severe sexual dysfunction, sexual suffering affects more men as compared to women, and liver transplant recipients were less satisfied with orgasmic strength, and quality of life and sexual function improved in both males and females post-liver transplant. And similarly, erectile functions, some studies have shown that in about 50% it is improved in some patients versus, and in some it remains unchanged. This was a study done by surgery department by Dr. Raj Kupala and Professor Pamecha. This study was on 98 patients. Ultimately, 62 were included after the inclusion criteria and evaluated at 3, 6, and 12 months. Two scores were used, SX score and IIEF 5 score. So etiology, obviously NASH and ethanol were the most common. Now, post-liver transplant, SX was declining. That means the sexual function was improving. Similarly, IIF scores were increasing. That means the sexual function was improving. And the scores are continuously growing up at 3 months, 6 months, and 12 months. And similarly, testosterone levels post-liver transplant were also increasing from pre-op 3 months, 6 months, and 12 months. Now, sarcopenia came out as an independent predictor of sexual function post-liver transplant. As we can see with p-values of 0.002. And there were other factors like BMI and MEL, which were also important. So, in sarcopenic patients, the testosterone recovery was less as compared to the non-sarcopenic patients. So, this would be an important factor because the sexual dysfunction recovery depends on patients whether they are sarcopenic or non-sarcopenic. So to summarize, both male and female sexual dysfunction are very common in chronic liver diseases. They are associated with poor quality of life. There are multiple associated factors and mechanisms involved. Detailed history, questionnaires, physical examination, assessment of associated factors, drugs, psychological factors should be done, and a multidisciplinary approach should be taken: hepatology, psychology, psychiatry, neurology, endocrinology, etc. And ED may improve post-liver transplant. So liver transplant is always a consideration whenever indicated. Thank you very much.
Very nice, Manoj, and very well presented. It only gives me a thought that we should have all our patients probably assessed once for sexual dysfunction, both male and female. And maybe tadalafil should be used. Maybe more studies we should conduct, and also for transplant. Very unexplored area, very few studies. And maybe the females also have low testosterone, and therefore we can give them testosterone also.
There was one study from ILB of giving testosterone, but the outcome was not sexual dysfunction.
Yes, muscle improvement.
So likely
Okay.
improve sexual dysfunction.
Any comments?
Yeah, I have one question. You
Sanat?
studied sarcopenia, but why didn't you study the quality of sleep and sexual dysfunction?
Already we have studied there, actually studied from ILB.
With sexual dysfunction.
We have not studied both combined.
Yes, thank you.
The individual cases, sleep study. There's a good idea with the combined.
Thank you.
Who complained of gynecomastia and mastalgia, severe mastalgia with cirrhosis. So such patients can be treated with radiation therapy if required.
Oh,